Hello, everyone. My name is Chelsea, and I am the PGY1 resident at Poudre Valley Hospital. And today I'll be discussing targeted drug therapy in refractory acute myeloid leukemia, more specifically the new drug ivosidenib or Tibsovo. I do not have any financial interests or arrangements that would be considered a conflict of interest. And here are the learning objectives I have outlined for this presentation. We'll begin with discussing the risk factors and pathophysiology of acute myeloid leukemia. Then we'll identify targets for treatment in acute myeloid leukemia. And finally, I'll describe the mechanism of action and the common adverse events that you can see with the new AML drug ivosidenib or Tibsovo. To start, we'll begin with going over acute myeloid leukemia, just so we can have a better understanding of what exactly is going on during this type of cancer. On this slide, I have an image of normal hematopoiesis as well as hematopoiesis during acute myeloid leukemia. On the left-hand side during normal hematopoiesis, we'll start with our myeloid stem cell here at the top. And that cell will differentiate down with the assistance of these different factors here until ultimately we have functioning dendritic cells, red blood cells, platelets, and macrophages. On the right side, we have our acute myeloid leukemia hematopoiesis, which also starts with a myeloid stem cell. However, something has gone wrong in this stem cell. And whether that's a mutation in a protein or a mutation in a certain receptor, the factors aren't affecting this stem cell in the same way anymore, helping it to differentiate. So rather than functioning cells, we get multiple proliferations of these leukemic blasts that are unfunctional. So AML is just that, the expansion of your myeloid blasts or immature white blood cells, and this occurs in the peripheral blood, bone marrow, and it can start to occur in other tissues like the skin. AML is the most common form of leukemia, and the NCCN guidelines stated that in 2017 there were about 21,000 patients diagnosed with AML. And there is still a high mortality rate associated with this disease. They estimate that about half of those patients will succumb to their disease, which just drives the point that we need more treatments, new drugs to help treat these patients. So this is a good image of some of the common symptoms you'll see with leukemia. Unfortunately, they're very nonspecific. So just because you have weight loss and fever doesn't necessarily mean you have leukemia. But some of the side effects do make sense as to why our AML patients would be experiencing them. They'll usually have low red blood cell counts, so they can have fatigue or shortness of breath, as well as low platelet counts, which can cause easy bleeding and/or bruising. To definitively diagnose AML, a bone marrow aspirate needs to be done. And to diagnose AML, there needs to be a blood myeloid blast count of greater than or equal to 20%. Once we have that diagnosis, it's important to get a CMP and a uric acid. These patients typically have high tumor burdens, so they can spontaneously go into tumor lysis. Otherwise, it's good to have a baseline lab measurement for before they start their chemotherapy treatment. LDH is used as a tumor marker for tumor burden, and CBC with differential helps to risk stratify them. For example, a white blood cell count greater than 40,000 is associated with higher risks of CNS disease, and you can get a lumbar puncture to confirm that. However, it is important that these patients have symptoms of CNS disease prior to the lumbar puncture, otherwise you could risk introducing cancer cells into their CNS. And cytogenetic testing is more important now than it has been in prognosis and treatment guidance. We don't wait for cytogenetic testing to come back. We'll begin chemotherapy, but once we get the cytogenetic results back, then we can further guide the patient's treatment. And these are just some prognostic factors. So patient-specific, we have age over 60, which is associated with decreased survival. And that does make sense because usually younger patients will have less comorbidities and can tolerate more intense chemo regimens. For patients that are over 60, you'll notice that AML is the average age of diagnosis is about 67, so most of these patients are past that point anyway. So in those patients, we're looking at their performance status and whether or not they can tolerate intense chemotherapy. And we'll also look at total white blood cell count at diagnosis, which again helps to risk stratify them. Treatment specific, a lack of complete remission after their first induction therapy is associated with a poorer prognosis, and a duration that lasts less than 6 months is also associated with that. This could just indicate a more resistant or aggressive AML type. So going back to cytogenetics, this actually helps with our prognosis of these patients. And they've gone back and evaluated the cytogenetic testing of patients with AML and found these mutations, and then evaluated what their treatment course was and how their disease progressed, and have been able to sort them into favorable risk, intermediate risk, and poor risk, as you see on this table. I'm only going to be talking about the ones highlighted in red because they relate more to our treatments. But for favorable, you'll see an NPM1 mutation without FLT3 and a double CEBPA mutation. And then you'll have a FLT3 mutation, which is considered a poor prognostic factor. So what exactly does it mean when someone has an NPM1 mutation? When they've looked back at these patients, they found that NPM1 helps to control duplication during the cell cycle, and it regulates the tumor suppressor pathway. They've seen this occur in about 28 to 35% of patients with AML, and patients with the mutation have an associated higher response rate and improved event-free survival compared to those without it, and they appear to respond well to chemotherapy. Then we'll have our FLT3 mutation. This is a poor prognostic factor. FLT3 is a receptor tyrosine kinase, and it's involved in stimulating growth response within certain cells. So it helps our cancer cells grow uncontrollably and to evade cell death. And there are two different types. You have your more common internal tandem duplication, and then the less common tyrosine kinase domain, and you can see where those are located on the image to the right. Patients with FLT3 mutations typically is associated with shorter remission durations and poor survival outcomes. And then we have our CEBPA mutation. This is another favorable prognosis. CEBPA is a transcription factor, and it's involved in differentiation of certain granulocytes. They see this in about 7 to 11% of patients, and patients with this mutation have associated increased remission rates and overall survival. So now I'll talk about IDH1 and IDH2 mutations because this will be important for the new drug that we're going to be talking about later on. Unfortunately, they haven't linked IDH1 or 2 with a prognostic factor yet. It's just an important target for targeted therapies in AML. But there's IDH1, which occurs in 6 to 10% of patients, or IDH2, which occurs in 9 to 13. And what exactly is IDH? It stands for isocitrate dehydrogenase, and in normal unmutated IDH, it confers enzymatic activity and produces alpha-ketoglutarate. The most important thing to know about alpha-ketoglutarate is it is critical for metabolic and cellular pathways and the leading of differentiation in these myeloid cells. Along with our new FDA-approved drug, we have a new FDA-approved test that'll test for this IDH1 mutation in our AML patients. This slide goes over the mechanism of what is exactly going on with an IDH1 or 2 mutation. So you can see your cell here, and it has a nucleus and a mitochondria. The important things to note are that IDH1 and IDH2 have the same mechanism. IDH1, however, is located in the cytoplasm, and IDH2 is located in the mitochondria of the cell. In patients with either one of these mutations, rather than producing alpha-ketoglutarate, they overproduce an oncometabolite called 2-hydroxyglutarate, or 2-HG. An accumulation of 2-HG can do 3 different things in the cell. It can cause hypermethylation of DNA, so it can't properly be transcribed. It can silence the cell differentiation pathways, and it can also disrupt the metabolic processes within the cell and cause something called BCL2 dependence. BCL2, as you can see in the bottom of this image, is an anti-apoptotic protein, and it helps cancer cells to evade cell death. Now let's talk about our AML treatment. The gold standard of treatment is chemotherapy in AML, and that hasn't changed with these new drugs, but I thought it would be important to go through them just so we have an idea of of what the normal treatment process is. So when you have a newly diagnosed AML patient, we'll begin with remission induction treatment, and that'll depend on their age. So patients under 60 can usually go with intensive therapy, and the most common regimen is 7+3, which can consist of daunorubicin or idarubicin plus cytarabine, or the other regimens listed below can be used. In patients over 60, we'll look at their ECOG status and comorbidities, and if they can receive intense chemo, then they can receive the above regimens. If not, we'll do low-intensity remission induction, which is the regimens listed below that are usually monotherapy. Once our patients are treated, we're going to monitor their response with a 14-day bone marrow biopsy. To look for success, we would like less than 5% of a blast count within their bone marrow biopsy, and this is specifically myeloid blasts. Complete remission is defined as an ANC greater than 1,000, platelets greater than 100,000, again, that bone marrow biopsy with less than 5% myeloid blasts. They shouldn't have extramedullary disease or any blasts with our rods because that can be indicative of leukemia. And they should be transfusion independent, and this includes red blood cell as well as platelet transfusions. Since there is a high degree of mortality with AML, it shouldn't be surprising that many of these patients become relapse or refractory. The only curative therapy for these patients is an allogenic hematopoietic stem cell transplant, and that's when you take healthy stem cells from a donor and give them to your patient. They will also undergo chemotherapy that's listed as these regimens below, even if they don't receive a transplant. The question comes, can you repeat 7+3 or a HiDAC regimen for these patients? And the answer is yes, under two conditions. They should have responded during their induction treatment, and their remission should be more than 12 months. So a true or false question, you have a 62-year-old female, and after being diagnosed with AML, she was started on 7+3 induction chemotherapy. She responded well. 13 months later, her AML has relapsed. Can she receive 7+3 again for her relapsed AML? And the answer is true, she can. So now I'm going to go into a patient case, and this patient is what drove this whole presentation since he is receiving our new FDA-approved drug, ifosidenib. So let me introduce you to ER. He's a 59-year-old male, and he presented to the emergency department at PVH with back pain that radiated to his left shoulder. He had presented similarly in February of this year, and he was diagnosed with a relapse of his AML. He was admitted based on an elevated white blood cell count, fever, thrombocytopenia, as well as neutropenia. His medical history is consistent with hypertension, and he was originally diagnosed with AML back in February of 2017 when he was living in New York City. His symptom upon diagnosis was gingival hyperplasia. For his social history, he's a former smoker, and he does occasionally use marijuana. His vitals on admission, he was tachycardic and had a fever. His white blood cell count was elevated. His platelets were low at 10. His ANC is 0.6, and his blast count was elevated at 25.6. For his past medications, he has hypertension, so he takes amlodipine and losartan. Otherwise, the rest of these medications are for supportive care to assist him since he started his cancer treatments. Upon admission, he had an MRI of his left shoulder and cervical spine, which was consistent with leukemia involvement. He had metastatic disease at C5 and C7, and on his CD abdomen and pelvis, he had enlarged lymph nodes. They did rule out a PE and a DVT with a chest X-ray and an ultrasound of his lower extremities. When he was diagnosed with his relapse in February of 2018, they did a pathology of that bone marrow aspirate, and they noted an NPM1 mutation, NRAS, and most importantly, an IDH1 mutation. Unfortunately, since this patient was originally diagnosed with New York, we do not have any of the records to know if he received cytogenetic testing originally and what those results would have been. In June of this year, he started to have some pain in his thigh, which led to a skin biopsy, and that showed leukemia cutis. Leukemia cutis is when those leukemic cells start to invade into the skin, and they cause these painful lesions. So I have another question. Which of the molecular mutations represents a favorable prognostic factor in AML? And you can review that. And the answer is C, an NPM1 mutation, if you can remember the table. So for ER's treatment course, when he was diagnosed in New York City, he was started on an induction cycle with 7+3, and from the notes it looks like it was cytarabine and idarubicin. He did do fairly well with this treatment. He did go into remission, but he was deemed not a transplant candidate due to his lack of social support. Then in April of 2017, he moved to Colorado and started treatment at UC Health and got a HiDAC consolidation cycle of high-dose cytarabine 1 gram per meter squared. The typical dosing for this is 3 grams per meter squared. However, due to his age and his poor performance status, his dose was reduced. When he was diagnosed with a relapse in February of 2018, he was given a reinduction cycle of idarubicin, fludarabine, and cytarabine. And then to assist with his leukemia cutis, he was started on palliative radiation. So let's start talking about our new IDH1 inhibitor, ivosidenib, or Tibsovo. So this was FDA approved in July of this year, and it's approved based off of a phase 1 trial that hasn't yet been published. And they have 174 patients with relapsed or refractory AML in addition to an IDH1 mutation. Each of these patients were assigned to receive 500 milligrams daily until they had disease progression, development of an unacceptable toxicity, or they could receive a stem cell transplant. The median age was 67 years old, and most of these patients had a good performance status with an ECOG of 1. For their efficacy, they found that there was complete remission in 24.7% of patients with a median duration of response of about 10 months. Complete remission with partial hematopoietic recovery in 8% of their patients with a median duration of 3.6 months. And all of the above responses were achieved within the first 6 months of treatment. So these numbers don't sound great, but when you think about the fact that patients who aren't receiving any treatment for their relapse or refractory AML could only live for about 4 months, we're extending that to between 6 and 9 with this medication. So to review its mechanism of action, we talked about what IDH1 mutations do within the cell. This drug targets IDH1 mutated enzymes and it causes decreased levels of 2-HG. So you'll see induced myeloid differentiation, reduced blast counts, and increased percentages of mature myeloid cells. And it's important to note that this medication isn't killing cancer cells like traditional chemotherapy, it's just turning cell differentiation back on. This is only indicated for relapsed or refractory AML, and it's dosed at 500 milligrams once daily for a minimum of 6 months, and then until there's disease progression or an unacceptable toxicity. The common side effects that they saw were fatigue, diarrhea, nausea, and anemia, and there were some adverse reactions of interest, which included QTc prolongation, IDH differentiation syndrome, which I'll explain on the following slides, and leukocytosis. So to start, we have IDH differentiation syndrome, and the pathophysiology of why we see it in these patients is unclear. But normally differentiation syndrome is seen in acute promyelocytic leukemia, or APL, and the proposed mechanism for that is with induced myeloid differentiation, you're releasing inflammatory cytokines that cause an inflammatory reaction within the body. So it's thought to be something similar to that with ivosidenib in AML patients. Specifically with ivosidenib, though, induced differentiation symptoms occurred with early evidence of clinical response, and they saw a rising leukocyte count with rapid neutrophil recovery. They had culture-negative fevers, pleural and pericardial effusions as well. And the other medications you can see differentiation syndrome with include arsenic or transretinoic acid, which are used in APL, and enasidenib, which is another targeted AML drug that I will discuss later on. This is a black box warning in this medication because it can be potentially fatal, and some signs and symptoms include dyspnea, fever, pulmonary edema, pneumonitis or pericardial effusion, hypoxia, or hypotension. They saw IDH differentiation syndrome in 19% of their patients with a median time of onset at 29 days. They did not report any fatalities to this syndrome, and no one had to permanently discontinue their medication due to it. To manage it, you'll want to start dexamethasone 10 milligrams IV every 12 hours for a minimum of 3 days. And you'll consider Lasix for any fluid buildups around the heart or lungs, and this is recommended in the package insert. They also saw some QT prolongation, so this was reported in about 24.6% of their patients. And they did allow them to use other QT prolonging medications, and most commonly patients were on Levaquin, ondansetron, or voriconazole. And the package insert does give some good guidance for managing this. For patients with QTc between 480 and 500, will interrupt their Tibsovo. Patients with a QTc greater than 500, you'll interrupt treatment and then reduce the dose when restarting. And you'll want to permanently discontinue it in patients with an elevated QTc and signs and symptoms of life-threatening arrhythmias. For patients that you'll be reinitiating therapy on after QTc prolongation, you'll want to monitor their ECG at least weekly after this for about 2 weeks. They also saw non-infectious leukocytosis with this drug, and that was defined as a white blood cell count greater than 25 or an absolute increase in their total white blood cells greater than 15 from baseline. They saw the side effect in 36.3% of their patients, and it did lead to a dose interruption in about 3%, but no one had to permanently discontinue. The package insert recommended management is hydroxyurea, 40 milligrams per kilogram a day, and you'll begin to taper that once their white blood cell count drops. And you can do leukapheresis, but this is institution specific. So additionally, ivosidenib is a 250 milligram pill-coated tablet, and it can be taken with or without food. You'll just want to avoid taking it with high-fat meals because it can increase the AUC. There are drug interactions with CYP3A4 inhibitors, inducers, and substrates, as well as QT prolonging drugs. And the average wholesale price is about $500 per tablet per Lexicomp, so a daily dose would be about $1,000. So back to our patient case. With his initial hospitalization, there was the plan to initiate ivosidenib, and this was based on his IDH1 mutation that was present from his 2018 biopsy, as well as this drug being newly FDA approved. So the Cancer Center got to work on getting this drug for this patient because unfortunately it's not on Colorado Medicaid's formulary yet, so he can't get it through that, but they worked out a deal with the drug manufacturer where they will provide it to him for free. However, 10 days later after he was discharged, he was readmitted for back pain, fever, elevated white blood cell count to 44, and neutropenia, and he still had not received his drug yet from the drug company. He was discharged and then readmitted this past week with increased weakness, pain, and lightheadedness, and began treatment for febrile neutropenia. His white blood cell count was 104, and he was started on treatment with hydroxyurea 1,000 milligrams by mouth twice a day for his leukocytosis. And finally, he received the drug and he started his ivosidenib on August 27th. Unfortunately, he's had a kind of complicated course, likely due to the advancement of his disease. After he received his first dose of ivosidenib, he decompensated a bit, and he was started on pneumonia treatment with Levaquin, vancomycin, and cefepime. And he also had some signs and symptoms of a differentiation syndrome, so he was started on the dexamethasone. After 2 doses of ivosidenib and a dose of Levaquin, he got a repeat EKG, and his QTc was 527. His baseline was 404, so his ivosidenib treatment was held and the Levaquin was discontinued to help his QTc get back to normal. So last question here, you have ivosidenib has a black box warning for what adverse reaction? And the correct answer is IDH differentiation syndrome. So now let me discuss with you some other targeted AML treatments. First, we have enasidenib, and this is indicated for refractory or relapsed AML, and it is for patients with an IDH2 mutation. So it has the same mechanism of action as ivosidenib, it's just for that IDH2 mutation instead of the IDH1. It's dosed at 100 milligrams daily, and it has a very similar side effect profile to ivosidenib, and its cost is about $1,000 a tablet. Then we have venetoclax. This is not FDA approved for AML, and it's normally used in CLL, but this is an orally bioavailable small molecule, and it inhibits the action of BCL2 proteins. Now, if you'll recall, BCL2 is that anti-apoptotic protein that helps cancer cells evade death. This drug helps to restore the process of apoptosis and kills these cancer cells. It's dosed as a starter pack, so you'll slowly increase the dose over 5 weeks, and this is helped to help reduce tumor lysis syndrome. Then we have midostaurin. So this is to target that poor prognostic factor of a FLT3 mutation, and it's a tyrosine kinase inhibitor, and it induces apoptosis in FLT3 ITD and TKD mutant leukemic cells. It's dosed 50 milligrams by mouth twice daily on days 8 through 21 as part of induction cycle chemo or consolidation cycle chemo. The reason it starts on day 8 is so that you can get your cytogenetic testing back after they have already begun their chemotherapy and get a hold of the drug. So hopefully that gives you enough time to do those things. And then, of course, there are always targeted treatments that are coming down the pipeline in oncology treatments. But we have a new drug application for first-line AML treatment, and they're looking at venetoclax plus azacitidine or decitabine and venetoclax plus low-dose cytarabine, and this will be in patients who can't tolerate intensive chemotherapy. And then since we have our new ivosidenib approval, they're doing a study in combination with venetoclax in IDH1 mutated hematologic malignancies to see if combo therapy is better than monotherapy in either of these drugs. And finally, these are just a couple new targeted therapies that are being studied. There's glitteritinib and quizartinib, which are both in phase 3 trials, and both are FLT3 inhibitors, hopefully to have indications in AML. If you have any questions about this presentation, please feel free to contact me. Otherwise, thank you for listening.